Hey, it's your old pal, Dr. Steve, and welcome to the SARS-CoV-2 COVID-19 updated situation report for May 3rd, 2020. This is the 7th in a weekly series. Previous episodes are available and have general information about the current pandemic that are not covered on a weekly basis. Okay, let's get started with the current statistics that we're following. So, we're looking at about 1 million cases in the United States with anywhere between 20 and to 30,000 new cases per day. And looking at this graphical representation, we're still in a linear configuration with our new cases. And Italy shows a nice S-curve that's starting to form there. This one looks a little bit unnatural to me. This doesn't, look at Italy's nice smooth curve, and the United States has a nice sort of smooth curve, and then this is just jumpy. So there's some issue with reporting there. I'm not going to make any guesses what that might be. Here's our new cases in detail. We are showing the 20-day moving average is leveling off significantly, although we're bouncing around quite a bit due to reporting. And remember, as we test more, we're going to have more and more new cases. And we're going to talk about that in a little bit, whether tracking new cases is really the way we should be going forward. Here's our Bollinger Band analysis, showing that the bands are still pretty narrow, indicating a decrease in the standard deviation in the data that's being reported, and that the new cases number is bouncing around between the upper band and the lower band, which is what it's supposed to do, and we show a significant leveling off. We'd like to really see a decrease in these new cases. That's probably going to be a while. So during this reopening and in this environment of increased testing, I'm not convinced that tracking new cases anymore is the most appropriate way to judge how we're doing with this. I think the more appropriate measure to follow during reopening is new hospitalization. So if you have a state that's decided they're going to reopen and they're also increasing testing at the same time, noting that they have increased number of cases may not be telling us the whole story. But looking at the number of new hospitalizations should indeed do that. Now, as we have new medications, testing these emerging new treatments against new deaths would be appropriate. So I'm going to start shifting to those metrics as the weeks go forward. And we can look at this right now. This is from covid.stoutlabs.com. And new hospitalizations in Georgia show a leveling off significant. This is the 20-day moving average, and you can see that reporting is up and down, but they show a pretty constant number of hospitalizations over time. So since Georgia is one of the first that's going to really open up their economy, it'll be interesting to see if this stays the same or increases. New hospitalizations in New York are falling off significantly. That's a pretty nice trend downward. Again, as New York starts to open up, we'll follow that as well, and we'll follow other states as they open and looking for new hospitalizations. Now, there's been a question, did the CDC cut the death numbers recently? And I've gotten in arguments on Twitter about this, and it is very confusing. So we're looking at WHO data showing 57,406 deaths in the United States as of the day that we're recording this, which is May 3rd. Johns Hopkins shows a higher number, about 60-some thousand. But then the CDC has this thing saying deaths involving coronavirus from February 1 to March 25th, 37,000. And so people are saying, well, they're revising this down. This is a scam, etc. Well, what that chart is a thing called the Provisional death counts. And these are based on death certificate data. And it says here as of May 1st, but you can see here that it was actually up till March 25th. I don't know what the disparity is here, if maybe the coder who's coding this page forgot to update this date. It is sloppy, though. But these are based on death certificate data, and death certificates can lag quite a bit. I know from experience that sometimes I don't get a case sent to me that's died in the hospital, sometimes until weeks after they've died, because they are trying to figure out who's going to sign the thing. So the funeral homes are kind of in charge of making sure that the death certificates are done. And so they have a patient that's passed away and they would need a death certificate. So often they will look around trying to figure out, should it be the attending physician, should it be the primary care provider? And then it gets into a system now in Tennessee. We have a system that is on computer, but it's really no faster than the paper system, other than the data gets into the main system a little bit quicker. So when it's done on paper, the funeral home has to find somebody, drop the death certificate off, you fill it out, you sign it, then they may come and pick it up today, tomorrow, next week. And then they have to, it sits on someone's desk until they put the data into the system. Some states that are still doing these in paper may be taking weeks and weeks to get this data in. And other states like Tennessee, it still can take some time. So that's why this is called provisional data. And provisional data isn't final data. And if there's any issue here, to me, it's that the CDC didn't anticipate this backlash in the way that they're reporting this, because this is really, I think, very poorly explained. And I'm not even sure useful. This is just the number of death certificates that have been reported, and it may be 3 weeks. And people say, well, how could they underestimate that much if it's only a 3-week lag? Well, it may be even a 4-week lag if this is actually data from last week. And then remember, in a situation where you've got accelerating cases and accelerating number of deaths, the majority of deaths will be recent. So if you have a dearth of data that's recent, then that could cut out a majority of patients. So look, I don't know. I'm interested in reality, and we have the Johns Hopkins data, we have WHO data, and then we have this provisional death certificate data. None of these will give us the exact number of patients that have died from COVID-19. We won't know that number until this thing is all over. And it's the same problem with recovered numbers. We won't know the number of people who recovered until we know the total number of cases versus the number of deaths. And then you subtract those two, and then at the end of this, when it's all over, we can say these are the number of people that recovered. So I don't know. It's very interesting, and I don't think that this is a conspiracy nor a scam. I think it is sloppy reporting by the CDC. Well, sloppy is maybe too charged of a word, but it's perhaps non-optimal reporting by the CDC in the way that they've done this. So we will know very soon what the real numbers are. I promise you that. As far as testing is concerned, we're up 1.3 million tests since last week. Still the greatest number of tests that have been performed by any country, but not per capita. Per capita, Italy is still doing significantly more, or has done significantly more testing per capita than the United States, although we're doing 20 cases per 1,000 people. I'd like to see that at 1,000 cases per, or 1,000 tests per 1,000 people. And again, just looking at Iceland, still kicking everyone's butt. I'd like to see some of their data on the penetrance of the virus on that island country that right now is relatively isolated, and where they are testing significant fraction of their population. Vaccine trials are ongoing. There is a governmental project called Operation Warp Speed, where there are 14 vaccine candidates. Looking like early 2021 at best, maybe January, February, we'll have this. But there is this Oxford vaccine. They developed it for other coronaviruses, so some of the safety testing's already been done. And they did prevent 5 rhesus monkeys from becoming infected. So they inoculated them with the vaccine and then tried to infect them, and they failed. So human studies are ongoing. We should have efficacy data by June. And this vaccine is conceivable before the first of the year. If everything goes perfectly, it's been estimated they could possibly have a marketable vaccine by September, which would be great. I'm not holding my breath until November or December, but it is very interesting, and we wish them Godspeed on this. So let's do a little diversion, talk about herd immunity, because that's what you're going for when you have a vaccine. Herd immunity has been touted by a lot as the answer to this crisis, and in fact, that's the goal of vaccination, so that would be the answer to this crisis. But can we allow ourselves to just get there by just allowing COVID-19 to just do its thing? That's one potential solution that some people have recommended to identify the truly vulnerable and let everyone else just sort of pass the virus around and isolate the truly vulnerable. So here's how you determine herd immunity. There's this calculation. We could derive it, but just trust me on this, and the derivation is online. And if you want me to do an analysis of the derivation of this formula, I'd be happy to do so, but I think most people just want to use the formula. So the formula is very simple. It's 1 minus 1 divided by the number of people each infected person will in turn affect, or the R0. So for measles, the R0 is 12. So F equals 1 minus 1/12. So F equals 1 minus 0.0833, and therefore F is 92%. You have to have 92% of people immune to measles to have herd immunity. But herd immunity isn't the end of the epidemic. That just gets your R0 less than 1, right? So let's say you decrease it to 0.9. If you reduce it to 0.9, 1,000 people who have the disease will still infect 900 others. So there will be some lag in the decrease in number of cases and deaths even when you reach herd immunity. So for COVID-19, the R0 is approximately 2.2. At least that's based on numbers that we have right now. So 1 minus 1 divided by 2.2 is 0.54, or approximately 55%. And remember, if the penetrance is much higher than we think, the number to reach herd immunity is also much higher. So if that R0 is actually a much higher number, because we did a bunch of antibody tests and found that 20% of the population already has it, for example, then the number needed to reach herd immunity will be much, much higher than 55%. So let's just look at that. If the current penetrance is 3%, the current numbers would have to be 18 times worse to reach herd immunity if we just let the virus do its thing. Be 1,800% more deaths, more hospitalizations, etc. And even if the penetrance is 14%, the current numbers would have to get about 385% worse, or 3.9 times worse. Vaccine is still a better strategy, in my opinion. Remdesivir got emergency FDA approval. They did a randomized, double-blind, placebo-controlled, multicenter trial in Hubei, China. These are the best kind of trials. And the eligible population were adults admitted to the hospital with lab-confirmed SARS-CoV-2 infection, radiologically confirmed pneumonia, and an oxygen saturation of less than 95% on room air. And they received Remdesivir IV for 10 days versus placebo, and their primary endpoint was time to clinical improvement. And the patients receiving the drug had faster time to clinical improvement, but it was not statistically significant. Adverse effects were about 12% in the drug and 5% in the placebo. So this is not the study that got Remdesivir emergency approval, but even it showed faster time to clinical improvement, although it was not statistically significant because it was a small study. So the NIAID did a study of 800 patients, was also blinded and placebo-controlled. Time to recovery was 11 days versus 15 days for placebo, which was a 31% decrease. Mortality was also improved, but it wasn't statistically significant. Now remember, when you've got a low number of people dying from an illness, then you have to have much, much higher numbers to show a statistically significant improvement. And in this case, the placebo arm was stopped early due to ethical concerns, so they may have reached statistical significance had they continued the placebo arm. This is my understanding. I've not read the paper yet, so this is pre-publication announcement that was made by the NIAID. So the future of Remdesivir is written by the fact that it's not a home run. But it is useful in our toolbox, which also includes convalescent serum, maybe hydroxychloroquine. Data is still out on it, standard respiratory support, treatment of the cytokine storm, and those kinds of things. So as this toolbox expands, more and more people should be helped with standard medical treatment. I still feel we need placebo-controlled blinded data in early treatment. And they say, well, it's a given IV, so we can only do it in the hospital. That's not true. We have infusion centers all over this country. It would not be that much of a stretch to allow people who were proven positive for COVID-19 to go to an infusion center and get 5 days worth of Remdesivir to prevent them going into the hospital and prevent deaths. So I would really like to see that data, and there is one study for Remdesivir that's in the works that's looking at mild to moderate disease. My new drug of interest is Favipiravir. Japan is providing this antiviral to 43 countries for clinical studies. It's already approved in Japan for influenza, but it's only approved if everything else fails. It's a broad-spectrum inhibitor of viral RNA polymerase, so it stops the virus from reproducing. There was an open-label study in China that showed 35 patients in the FPV arm versus 45 in the control arm, and there was shorter viral clearance, 4 versus 11 days, with a highly statistically significant result, and improvement in chest imaging in 91% of patients compared to 62% of patients. So, and I've given you the link to that article. So this may be a very interesting drug. It's a pill form, so it could be just prescribed and filled at a pharmacy and given to people who are in the early stages of this disease. If this medication can reduce hospitalizations to influenza numbers even, and reduce deaths to similar numbers, then this could be the true game changer. So it's not been tested in pregnant women. There was some concern that it could be teratogenic, meaning that it could cause birth defects. So pregnant women would still be considered highly at risk, although they're at no significantly greater risk from COVID-19 than any other respiratory infection that we know of, and there doesn't seem to be risk to the fetus other than the risk to the mother. But pregnant women are notoriously susceptible to respiratory viruses. Things happening this week, there will be more reopenings, and we'll be tracking new hospitalizations over the weeks. Those numbers will lag. So if you don't see anything in the first week, maybe even 2 weeks, that may not mean very much. But right around 3 weeks, we should start to see whether reopenings have been successful or not. There will be a lot more testing to determine the penetrance of this disease, which right now is estimated at 1 to 6%, although there have been some estimates as high as 20% in some hotspots. And determining this real number is essential. So widespread antibody testing is ongoing, and it needs to be very specific for this coronavirus and not show false positive data or numbers for other coronaviruses. There was an LA drive-through study for antibodies that showed 4% of their population that they tested were antibody positive. New York had one study of 3,000 random people that showed 14%. So there's going to be some regional differences. And again, knowing this number across the United States will be extremely important going forward. In the meantime, isolate as required by your locality. Wash your hands. Soap is always better than gel, but gel's better than nothing. Wear a cloth covering when social distancing is difficult. Also, depending on local mandates, check out our Twitter at Weird Medicine and our Sirius XM show on the Faction Talk channel on Sirius XM channel 103, 8 p.m. Eastern on Saturdays, 5 p.m. Eastern on Sundays, and on demand. Until next time, see you next week for the next Weird Medicine COVID-19 situation. Stay healthy, everyone.